Anyway, so we were talking about our second generation antipsychotics, and we talked about our first gen. What were the main differences between those two classes in terms of mechanism? Yeah. So first generation only focuses on what? Yeah, blocking dopamine 2 receptors specifically, right? And remember, they still have a lot of other effects on different receptor subtypes. So you have like the antimuscarinic effects. Remember, we talked about like high potency D2 blockers. We talked about low potency ones. Which ones tended to have higher anticholinergic effects? Higher low potency D2 blockers. The low ones, remember, so like Haldol and fluphenazine, they were really high potency. Remember, they had like 4 pluses on their little check boxes there for dopamine actions. They had relatively low antimuscarinic activity, right? And because they are high potency D2 blockers, what does that put the patient at risk for? Those Parkinson-like effects, right? The extrapyramidal side effects, those acute dystonias, those are more likely to see with the high dopamine 2 receptor blockers. On the other hand, with the low potency ones, right, they had a lot more antimuscarinic effects. And so remember, how do you treat those acute dystonias or those EPS symptoms? You give them Benadryl because Benadryl has anticholinergic properties, right? So again, that's why we see less likely, those low potency agents have less propensity to cause EPS-like symptoms, mainly because of the fact that it has more anticholinergic properties, and it helps to kind of balance out that seesaw effect from blocking dopamine causing way too much acetylcholine activity, right? So good things to remember. Getting into the second generation ones, remember those are atypical antipsychotics. They are still having some activity at the D2 receptors, but they are now moving towards blocking serotonin receptors as well, right? If you recall that. And in terms of like clinical efficacy, what were kind of the differences between a first gen and a second gen agent? So what kind of symptoms were like the first generation agents really good for? Remember those positive symptoms, right? So if I have a patient who's like acutely having a psychotic episode in the ER, and they think that the CIA is out to get them and all these things, they may be kind of agitated, maybe aggressive. That's where a first generation agent can be really good because it helps decrease those positive symptoms. The second generation ones we'll see are going to be better for those negative and the cognitive symptoms, right? Because they're kind of helping out with the effects in the frontal cortex, and so that can help out quite a bit there. So we talked about in terms of side effects, again, there's a lot with the second generation ones, there's a lot of weight gain associated with those. They can cause things like QT prolongation. They also can have some strong antimuscarinic effects, things like that. And in general, they, as a class, both first and second gens tend to be sedating in a lot of cases there. So frequently may dose it at nighttime to avoid some daytime grogginess there. Getting back to the second generation ones, a lot of these interactions that happen here tend to be more pharmacodynamic in nature. So for instance, if I had a patient who had an anxiety disorder and they had schizophrenia, they're on say a benzodiazepine for that, plus an antipsychotic. Synergistic sedation is quite common. If they're on maybe an antihypertensive, because now based on their weight gain, they're hypertensive now, blood pressure meds are going to be interacting from that standpoint, right? Those things you can expect to see. If you add on, say, other dopamine blockers, so say they are receiving Reglan for nausea, vomiting or something, that's where you can increase that risk there, right? Remember, promethazine also kind of falls in that category of being anticholinergic, but also blocking some D2 receptors, okay? So this is a good kind of table, and again, don't memorize like if it has 3 asterisks or 1, but again, you kind of get a feel for the general side effect profile. Which ones do we say were kind of like the ones you probably want to avoid just in terms of side effect profiles? So there's 2 main ones. There's clozapine. Remember, that was the one that can cause agranulocytosis. Like you have to be logged in with a program to make sure you're getting your CBCs done regularly, to make sure you don't have agranulocytosis that can develop. That one's pretty bad. That one is going to be for more treatment-resistant patients. They've failed several other agents. Olanzapine tends to be fairly bad as well from that standpoint. So for instance, here you're going to see there's a lot of weight gain associated with it. Quetiapine or Seroquel can also do that to a large degree. But again, you're going to see more akathisia, more somnolence. So olanzapine is probably another one I would probably avoid using as like a first line here. But things like Abilify, especially like aripiprazole, tend to be pretty good from that standpoint. They have a pretty favorable side effect profile as compared to the other ones. Remember, second gens can still cause EPS symptoms. It's just less likely because they're not going to be as potent at blocking those D2 receptors, right? Again, this is another set of drugs we're going to see new ones coming out all the time. So things like paliperidone, acenipine, lurasidone. These are ones that like weren't out when I was in school, but they've been coming out. So this is still kind of a developing category. Seeing a lot more of these. They're being developed, from year to year. So. Other ones you may run into, like I mentioned, these are kind of newer ones, just to give you an example of all these things. And again, if I were to have a patient who were to come out and they're on this brexpiprazole, I've never heard of that before, but I can at least look it up. And as soon as I see it, hey, it's a second generation agent, I already know a lot of things about that drug, right? So this is why it's really good to know things in terms of classifications, in terms of broad categories, because even though I've never seen a drug, just by looking it up and it says second generation antipsychotic, boom, I know a ton about it. I know the mechanism, I know common side effects, I can speak intelligently to that patient about that particular drug, right? So all things to consider there. And again, looking back at this table, I think this is a good one to compare the side effect profiles between the atypicals and the first generation agents there. Again, typically you're going to find that all of them can be sedating to some degree, some of them more so than others. You're going to see a lot more of the metabolic effects with patients that we're seeing the second generation ones, right? Because again, those are going to be causing a lot more weight gain, causing dyslipidemia, glucose intolerance, etc., right? So a good table to kind of go back to and just kind of reference. How we're going to monitoring these patients, again, look at their weight, blood pressure, kind of like typical stuff you'd be doing anyway for most patients when they're coming back for their visits, but certainly look at their potential side effects from these medications themselves. And again, the patients may not know what is a side effect of the medication, so you have to ask about things specifically to make sure that, they may think that they're just getting older and things are changing and that's just normal for them now, but it could be related to the medication. Again, with the second generation agents, do I have to worry about tardive dyskinesia? Generally, no. It's a fairly low occurrence with that one as opposed to the first generation. That's another point I wanted to make. Is that's what, again, why we like to use those second generation ones as a first line agent, because that way it helps to prevent a lot of that tardive dyskinesia from occurring over the long term. So imagine we have a patient who's coming in for, say, an acute psychotic episode. They're in the ER. Like I mentioned, they're aggressive. Maybe they're having some delusions, things like that. Initial goals are to try to get patients kind of under control, kind of get them those positive symptoms dealt with first, because those tend to be the things that make them the most agitated and can be potentially dangerous. So we want to take care of those. And so in some cases, you may start off with using something like an intramuscular agent, because do you think if they're in the midst of acute psychotic episode, they want to take things orally? Unlikely. They're probably going to want to spit at you more than anything else, right? Do you think you're going to get an IV easily on those type of patients? No. So ideally what you could do is like get like a blow dart and just kind of get them intramuscularly from across the room. That's probably the safest thing, but unless your aim is very good, then that's not really all that viable. But intramuscularly, that's certainly a good route to go, and so a lot of these do have those options available to them. So like an IM dose of Haldol, and then we can also give them a benzodiazepine will also help out. Remember, very synergistic sedation, so it's not uncommon for them just to kind of pass out after that. They'll still be breathing, right? There's not a lot of respiratory depression associated with these, but certainly they'll be pretty zonked out, and they can kind of do what you need to do. If you need to rule out other medical things like meningitis or other things, you can get their IV started, you can do whatever you need to. And so once that's kind of done, you say like, put them in they always say like put the patients in a calm environment to try to help chill them out. But like, has anyone ever been in an ER with a calm environment? Unlikely. We used to have what we called the fishbowl in our ER where I practiced, and basically it was a room with glass windows in it, so that way they put all the Baker Acts and the psych patients back there. There's a couple of sitters back there, and that was a room that was meant to be the calm room. The lights were off, but that's like where you put all the patients who are like really aggressive and agitated together. It's like they just egg each other on. It was a nightmare. But things to think about, right? So again, try to get them calm and sedated, deal with those initial positive symptoms. Then you want to get them on maintenance treatment, and again, compliance is going to be a big issue with a lot of these, and so you may have to try to switch around and figure out which agents are going to work best for your patients. Typically, second generation is going to be the first ones to start out with, and look to see like how they respond to it. If you start them out on the agent and their symptoms are under control, but they put on like 20 pounds, like that may not be great, right? Remember, more than 5%, you want to consider switching them out to something different. As I mentioned, looking at the long-acting injectable forms, typically these are either in sort of a less soluble sort of solution, or they may be like in an oil base. So for instance, like Haldol when the IM formulation that's meant for long-acting effects, the depot form, typically comes in an oil. And again, the oil doesn't like to dissolve into the bloodstream very quickly, so it just kind of slowly leaches out the drug over the course of months. And that can be beneficial because that allows for ensured compliance. You know the med's there, right? What could be a potential issue, though, if you did an IM injection of one of these long-acting drugs? You can't take it out, right? Once it's there, it's kind of there. So in those instances, it's not like an implant or something where you have an actual device you could remove. In these cases here, this would not be the first step, right? You'd want to get them stable on an oral regimen, see which ones work for them, and then you could switch them over to something intramuscular, right? Again, these patients may, for a period of time, be in a place where they're more monitored, especially if they're like in a psych facility or something like that. But once they get out, that's when the issues of compliance really are going to rear their ugly heads. So most of the time you're going to find this, again, kind of a nice little flow chart here on how to manage this. I'm not going to get into the different subtypes of schizophrenia, but basically you're going to find that most patients are going to do well with the second generation, mostly things like aripiprazole, risperidone, or ziprasidone. They typically have the most favorable side effect profile from a metabolic standpoint, and they still have pretty good efficacy there. And then you just kind of see how they respond, right? So again, if they're failing one, you can try switching over to other patients. Just will have some variability in terms of how they're going to respond there. Typically, clozapine is going to be, again, third, fourth line agent because it is so risky in terms of causing the agranulocytosis. If you don't have to use it, it's, and again, patients enrolled in that, having them come back for their weekly CBCs, it can be a big issue too. So occasionally you may find you typically don't want to mix two different antipsychotics together because you'll typically find those will cause worsened side effects, things like EPS symptoms and whatnot. So I probably wouldn't recommend that. And again, you may find that you have to treat other things as well, right? So they may have concomitant depression you need to manage, right? So they may be on SSRI plus an antipsychotic. You may need to consider these other things as well, maybe a mood stabilizer if they have bipolar disorder. So it's important to kind of delineate and treat each individual issue because otherwise it can exacerbate one another, right? Okay. Typically, you don't want to abruptly discontinue these meds because they can cause a relapse of symptoms. So ideally, you'd like to taper over 2 weeks or so. If you're tapering to start another agent there, you can try starting it maybe after a week or so, starting a low dose on the new agent and then gradually titrate that one up in order to make sure they don't have any real big lapse in medication exposure there. And so that's typically the way you kind of switch those around. The nice thing with the intramuscular long-acting forms is they have a really long tail in terms of their drug level, so there's kind of a natural taper built into them. And especially even if, say for instance, the med's supposed to be given every 3 months, even if the patient comes in a couple weeks late, there's still some drug in the system, so they don't really have to worry about an acute withdrawal from the medication itself. Some of those withdrawal symptoms they can see include things like insomnia. They can have recurrence of a lot of those positive symptoms. They may have like nightmares that can develop there. Typically this is not going to be as severe of a withdrawal syndrome as you would see with like an opioid or a benzo or something like that, but maybe on par with something like say a SSRI or something similar to that. So any questions on that section? You've probably been able to tell that some of your professors probably need some antipsychotics, right? Most likely, but which one would you put us on? Clozapine? That's so rude. You start us off on the most dangerous one right off the bat? Boy, no golden apple for any of us this class, I can tell. Maybe a golden apple laced with clozapine. Okay, so moving into some anxiety disorders, there's a lot of different varieties that are here. Certainly, things like obsessive compulsive disorder kind of fall into this. Post-traumatic stress disorder is a really big one, especially, we have the VA here in Orlando, and so that can be a big source for a lot of those patients. I have a pharmacist friend who works at the VA in Daytona, and all she does is psych stuff. And it's really cool from a pharmacist perspective working for the VA because the VA is kind of like it's a whole other system, right? And so they have a lot more free leeway for pharmacists to actually manage a lot of these patients' medications without necessarily having to have like a provider sign off on it, which is pretty cool. And so all she does is psych stuff with these vets, and it's really interesting her talking about how these different ones are working and how they're starting to see some new novel therapies for things like PTSD. I know I've mentioned the drug ketamine before. Anyone remember that one? It's like a Special K, right? So it's like a horse anesthetic, but we use it for people too. But they're finding now that by using like really low doses of ketamine, they actually are having some really good treatment effects on PTSD and things like that. But or it could just be specific phobias, right? Now, are these anxiety disorders, are they going to be like kind of a constant thing? Are they going to be more intermittent? It depends, right? So it's another one of those questions where it depends. It's always a safe answer. For instance, if it's more of like a performance anxiety, like you have a big speech that's coming up and you have to speak in front of all your peers, like it's a very specific sort of one and done kind of thing, right? Versus if it's going to be more, you're just at baseline, you're just always worried about something, you're always kind of, your hackles are always raised, so to speak, that something's going to come around the corner, like that's more of a constant thing. And so treatment will differ between those two there. And again, what was that? Is it a sneeze? Okay, sorry.
It always throws us off too.
Oh, weird. I have a pharmacy tech that I work with that has like some weird like hiccup issue where she just like has like chronic hiccups, and so but it's like very high pitched. It's like it's just like at random moments. I'm like, what was that? Did you actually know? But that is apropos because actually one of the treatments for chronic hiccups is actually some of the first generation antipsychotics. They may see patients on Thorazine to use that. So that's another little bit of trivia for you. Anyway, but looking at anxiety, right? So typically this is like a maladaptive response. Like a little bit of anxiety can be appropriate. Like, if you're in a dangerous situation, it's okay that your fight or flight response is kind of activated because you need to be able to respond to stressors if you need to. And again, you're typically going to find that there's a lot of norepinephrine at play here. Serotonin can have some role. And then also GABA, we'll find, is also another important neurotransmitter because we'll see that's a big help for treating acute symptoms of anxiety. There are also possibilities. So for instance, you can have HPA axis issues, like for instance, if you have hyperthyroidism, right? You may have anxiety related to that because you're in this like kind of hypermetabolic state, everything's kind of ramped up to 10. So you can see lots of things that can cause that. A lot of medications can cause anxiety too. So like we mentioned with the antipsychotics causing that akathisia, that frequently kind of feels like anxiety because again, you have that kind of ants in your pants kind of feeling there. Other things like a lot of stimulants, so amphetamines, which we'll talk about later on in the ADHD section, cocaine, things like that can certainly lead to that. A lot of hallucinogens can lead to anxiety. Even things like marijuana can certainly lead to some anxiety and paranoia, things like that. Typically, you're going to find other drugs that can lead that, actually withdrawal of certain substances can lead to that too. So things like alcohol withdrawal or benzodiazepine withdrawal also can lead to those symptoms of anxiety, right? So typically we're going to see that treatment is going to either be based on how the patient's presenting. So if they're having like an acute panic attack, like it's going to be very different treatment than if they're like, yeah, I feel kind of anxious all the time, more like kind of maintenance, kind of chronic therapy there. So we'll talk about some different options. For acute management of anxiety, so I have someone who's like about to like hyperventilate themselves to passing out and they're having a really severe panic attack, benzos are going to be like the way to go, right? So you can give them a dose of like Ativan or Versed or Xanax or anything like that. You know what the street name for Xanax is? I never heard of this. Yeah, why do they call them bars? Yeah, the tablets actually come in like little bars, so you actually they're scored, and so they look like the big Tetris piece, the L piece. I guess not the L piece. What is it? The I piece, the big one. So you can actually break it into portions there. So they call them Xanny bars or bars. Again, useless trivia. Maybe not useless though. If your patients come in and say they're taking some bars, you would not know what that means, right? You'll find that those benzos are going to be good for sort of acute anxiety management. You'll find them for more chronic management, though, for things that are going to be more kind of long-standing. Antidepressants are going to be the way to go. Typically, SSRIs are going to be kind of the first thing we'll try out. Remember, some SSRIs can actually cause anxiety in these patients, so one thing to be cautious with. SNRIs, you'll find maybe not so much because, again, that extra norepinephrine may actually also exacerbate their anxiety, so that's one thing to consider. And we'll look at a few other alternative options, things like Buspirone, which is a new drug, and we'll look at our second generation antipsychotics. This is rare that you ever need that, but it could happen. So as I mentioned, our antidepressants are typically pretty effective for that long-term generalized anxiety disorder. Certainly they could help out with some of the other ones as well, things like OCD and whatnot. In terms of what's been approved, certainly just because it doesn't have an FDA approval doesn't mean you couldn't use it. It stands to reason that if paroxetine works well, there's no reason that something like For instance, fluoxetine would not work, right? So they can just try it out and see how they respond to that. Remember, anxiety and depression typically go hand in hand in a lot of patients, and so you may be able to manage both of these by initiating one of these medications here. Sometimes you may utilize like a TCA. These are typically more second line, a whole host of side effects we've already talked about ad nauseum, so we're not going to go over that again, but just know that could be an option if they've kind of failed some of those more first line agents. We don't really know why these work necessarily to help out with anxiety, because again, having this maladaptive stress response where you're just always kind of on edge, by affecting serotonin, we don't really know why that leads to helping with that anxiety, but we do see that does have some efficacy there. Remember, these are still going to take a couple weeks to kick in, so if they need something to hold them over in the meantime, that's where maybe like a short-term benzodiazepine might be useful, and then you could have them start on the SSRI at the same time, so hopefully by the time they run out of their benzos, the SSRIs are kind of kicking in and doing their thing, right? And again, same side effect profiles you would see as what we talked about before. So remember how our benzos are going to work? Basically, they're just kind of chilling everything out in terms of the neurons and hyperpolarizing them by helping to allow GABA to bind more easily to the GABA A channel, and that allows that chloride to flow in unless you have the hyperpolarization there, right? The resting membrane potential gets more negative, and so it's harder to have that action potential there. We have a lot of them that are available. We've mentioned several before when we were talking about anti-epileptics. Those are the ones we typically would use, say, for like acute seizure management, things like lorazepam and midazolam and diazepam. Those are all ones we typically see for seizure management. Other ones that are more common for seizures are like clobazam and things like that. Here you see there's just a ton of them. Like they've been around for quite some time. And so some of these you're going to find are, they vary based off of they're more water soluble, more lipid soluble, based on if they are renally eliminated, hepatically eliminated. The problem you run into, especially with elderly patients, is that they can't clear the drugs, or say if the drugs have active metabolites they can't clear. Well, guess what? Levels accumulate, and then they can definitely experience some significant toxicity, CNS depression, if you start mixing with other drugs, respiratory depression, so you worry about that, right? I've mentioned the Beers list before. We'll talk more about that in geriatrics, and I think Professor Gherkin might be teaching that section for you guys in CMS, but we'll mention the Beers list as being like kind of a list of medications that are more dangerous or more, maybe prone to causing side effects in elderly patients, and a lot of the benzos are going to show up on there. In fact, a lot of the first generation antipsychotics show up on there. A lot of the psych meds do happen to be on that list due to side effect profiles. However, there are 4 benzodiazepines that are better in this elderly population, mainly because they don't have active metabolites, they're relatively short-acting, and they're renally eliminated, so that way you don't have to worry about hepatic impairment affecting that. The 4 that will be on there are called the LOT benzodiazepines. I have them starred on here. So it's lorazepam, oxazepam, temazepam, and triazolam. Those are better for elderly patients because, again, they don't have to worry about any kind of CYP interactions from a hepatic standpoint. They're more water soluble, so they're able to clear from the kidneys easier. They don't have a lot of body tissue buildup that happens with more lipophilic meds. No active metabolites, so they're really kind of more designed to be easily processed and eliminated from the body, such that elderly patients have less likely to run into issues. Does that mean that they're going to be side effect free from taking these drugs? Certainly not, but they're going to have a more favorable side effect profile compared to something like diazepam that's highly lipophilic and they have some active metabolites that stick around for a while, right? Kind of makes sense? Remember the LOT benzos, lorazepam, oxazepam, triazolam, and temazepam. Those are the 4 big ones, okay? Now again, you could use these either as acute management, so maybe just like a one and done kind of dose, or maybe as like an as needed sort of thing. Some patients will require sort of around the clock sort of management there, right? And so what's the concern of a patient taking it sort of around the clock for maybe several months, maybe years in some cases? Certainly side effects. What happens if they run out? Withdrawal syndrome, right? And then again, a big symptom of withdrawal is going to be what? Anxiety. Well, seizures certainly at the far end of that, but well before then they get very anxious, right? And so you'll see patients, and at least I've seen that in the retail setting, where they would come up and say they were maybe self-dosing a little bit too frequently, and they end up running out early, right? So you get one of those dreaded errors that says refill too soon, and they get very anxious when you tell them that, because they're like, I need my meds though, right? So it can become very distraught, and that just helps to worsen that anxiety as well. So that can be a really tough situation. So make sure they're only taking it like they're supposed to, Again, tolerance can develop to some of these effects. You may need to go back and revise your dosing with them, but you have to make sure that they're not going to be caught cutting it off cold turkey, because again, you can have a lot of that rebound anxiety, which can lead all the way up to those seizures, as we'll see. Okay, we've talked about other uses here. Now, as I mentioned, if it's just like a one-off thing, you don't necessarily have to worry about, you know, chronic effects and chronic withdrawal that can occur there. You know, if it's just like an acute panic attack, they come into the ER, they get a one-time dose, and that's it. You don't have to worry about that from that standpoint. And again, we use it for lots of other things too. As I mentioned, I'll kind of go into more detail on the kinetics of these drugs. Remember, some of them are going to have varying degrees of lipo versus hydrophilicity. Here you see like diazepam and clorazepate, really high lipid soluble. And that means if you're taking it chronically, those body tissue stores can build up, such that if they do stop taking it, maybe they actually will have kind of a nice tissue reserve, and those levels will go down a little bit more slowly than it would be if it was, say, very water soluble and it was able to clear out much quicker, right? And again, compared to like oxazepam, it has really low lipophilicity. You won't see that same sort of body store. The volume of distribution will be much lower from that standpoint. Most of these patients, if they're taking it chronically, will be taking it by mouth most of the time. However, if they're showing up having acute panic attack, maybe IM, IV is going to be an okay option for them as well. It just depends. Several of them may be metabolized through CYP3A4. Actually, most of them will, but as I mentioned, things like lorazepam and oxazepam, part of that lot list, they do not. So they are not going to be subject to those interactions if you have something that's inducing it or inhibiting it potentially. Clonazepam is another one there. Klonopin, another one that does not get metabolized through CYP3A4. So be careful with liver dysfunction. Be careful if they have active metabolites, because they can hold on to those and they can build up levels of that if they have poor organ function, right? Oops. So in terms of adverse effects, again, CNS depression going to be the biggest thing we'll see there, just like we saw with treatment for seizures. And again, you might find that the dosing will be a little different. Like if I'm having a patient with an acute panic attack versus a seizure, which one do you think would get the bigger dose? Probably the seizure patient, right? So again, dosing will change there, and the degree of CNS depression may be different between the two, as you'll see. Again, be really careful if you mix these with other CNS depressants. So it's not uncommon. They have these mixed with alcohol, and that can be a big issue. I remember there was one person I'd heard from that was in college. This was like years after they were in college, but they're like, yeah, I would just go out to the bars, and I would just take a Xanax, and then I would just have one drink, and then that was it. And that was a really cheap night out for me. I was like, why are you doing that to yourself? That's really dangerous. But they did just fine with it, right? So again, people will find a way. Also, things like memory impairment can be a big thing you'll see with these. So, and again, especially if mixed with other CNS depressants. But we actually do this for our benefit when we have patients going back for surgery. So in the pre-op setting, we'll frequently give them a dose of midazolam, and it kind of produces this kind of like twilight sort of semi-unconsciousness where they're kind of getting chilled out, and they don't really remember a whole lot, right? So just similar to alcohol, they can have brownouts and blackouts. Same thing can happen with the benzos as well. So no real difference there. Now, say paradoxical excitation, what does that mean?
Instead of being sedated.
So instead of being sedated, they get
Very excited.
very excited, yeah. So you can see this sometimes. Sometimes in adults, it's pretty rare. Most of the time, you may see this in kids, okay? Every time I don't make that caveat, I don't say anything about adults. I always have like one student in there who's like, well, I know somebody that had that, so I make the caveat. Yes, it can happen to anyone, really. But typically, this is going to be seen more often in children, where you give a dose of a benzodiazepine, and all of a sudden, they get like just crazy excited. They're going to be bouncing off the walls. You're just like, I gave you a benzo, you should be sleeping now. They're going crazy, right? The issue with that is typically you're kind of like taking the brakes off of like an excitatory system, so you almost like kind of didn't give enough of a benzo, and so they get really excited. So I kind of liken this to drinking alcohol, where if you have like a drink or two, are you like on the floor passed out? Typically, like, but what's your mood like?
Chipper.
Kind of happy and chipper, and I'm going to be like, I'm going to go talk to that girl over there, and like, you know, you get a little more excited. But then if you get to like 4 or 5 drinks, you might be on the floor potentially, or depending on what kind of drinks you're imbibing at that point. Anyway, the point being is it all has to do with the dose response, right? So you can see this in kids too. Typically, they do get that kind of excitation, they get that anxiety from that. You can't just give them more benzos, and guess what? Eventually, it'll just kind of overflood the system, and then they'll be certainly sedate. So one thing to consider with that. You see the same thing with Benadryl. I know we've mentioned that before. So Benadryls and benzos, you can certainly see that paradoxical excitation more often in kids. Withdrawal, again, can be fatal because of the rebound seizures that can occur there, so you do want to be cautious with that. But certainly anxiety, agitation, tremors are all going to be much more common and very likely you'll see with these patients if they're on it chronically. So as an alternative to that, you could use something like Buspirone or BuSpar. This is basically an anxiolytic that's non-benzodiazepine. It's also not going to be nearly as effective in a lot of cases there. But the benefits, though, and again, are any of the meds we just talked about controlled substances? Yeah, all the benzos are, right? They're all going to be C4s. Here we have Buspirone. It's actually going to be a non-controlled substance. It does not provide any sort of the same sort of like physical dependence or anything like that you would see with the benzo. So this may be a good option for patients who maybe have a history of substance abuse who still needs an anxiolytic. This may be a good option for them potentially. Maybe not as effective, but and you may find this may be an add-on to other things. So maybe they are on an SSRI, but maybe add on Buspirone potentially to that. Again, mostly it's second line though, because you don't have as much consistent effects as you would see with something like an SSRI or benzo in those cases there, right? It takes a couple weeks for it to kick in. Side effect wise, not a whole lot of issues there, very well tolerated for the most part. We don't really know the full mechanism, but probably has something to do with some partial serotonin 1A receptor agonism, but again, we don't really know. A lot of these drugs, we just don't know how they work. This is metabolized by CYP3A4, so we would want to watch out if anything might interact with it, either inducing it or inhibiting it. Okay, so beta blockers. Why would I mention beta blockers in terms of anxiety? So it actually works to block a lot of the physiologic effects of anxiety, right? So if I asked one of you to come up here and give the rest of this lecture, would anyone be anxious about that?
No.
No? You guys are all rock stars? Good public speakers? All Toastmasters? Let's say for the sake of argument's sake that, that someone came up here and they were very anxious about giving a talk. How might they look? They'd be shaky, they'd be sweating, heart rate would probably be slightly elevated, or if not, in SVT practically, right? Heavy breathing, right? All those things you'd expect to see with an anxiety attack, right? And so what's nice here, and again, imagine if you had to do something scholarly and talk about maybe medications or something else. Using a benzo, would that be necessarily to your benefit? No, I would not want to come up here after taking a benzo and try to give you guys a talk. Actually, you might find it entertaining, but I would be very unproductive, right? But point being is that you don't want that CNS depression happening there. Or say you're going in for a test and you're feeling very nervous, you want to take a benzo right before that because again, you may all of a sudden not remember some facts you needed to know for a particular question or something. So in those cases there, you can actually end up using a beta blocker. It's not going to cause any CNS depression from that standpoint, but it helps to mitigate a lot of those like sympathetic effects you're experiencing when you experience anxiety. So it helps out with the tremulousness, right? It helps out decrease sweating, keeps the heart rate under control. So you may be anxious, but you don't feel as anxious. The body's not going to be showing those things. So we will do this frequently for like performance-based situations, so like giving speeches or maybe like in testing purposes, or if you have like you're playing music or something like that. Those are good options there. Again, this would be something where it would be very intermittent, only if you needed it for the given event, right? I remember when I was in school, we had this class called pharmacotherapy. On my campus, we only had 50 students. It was a distance campus. And so we basically had this class where we had like one facilitator in the front of the room, and they were like the expert in the field, like cardiology or whatever. And they would call on students at random to stand up. And we'd actually, we'd worked up this case, we'd had a whole week to work on this case and came up with a plan and everything, had all the studies to back it up and all that. And they'd call one person at random, and they'd stand up and they'd ask you a question, and you'd have to like defend your answer, right? So they say, well, in this study you said this, but what kind of patients are they looking at? What's the patient population? And they just grill you, right? Needless to say, it was a very anxiety-inducing sort of event for me, right? So I was like, man, this is a really tough class. Like, I'm really feeling really anxious when I get called on. But I had some other people that were in the class who were like, yeah, I don't have any problem with it. Take my beta blocker beforehand. I'm like, what? Performance-enhancing drugs? This is ludicrous. So I said, no, I'm going to do it the old-fashioned way, and so I just got to be in the class. But it's a stain on my record. But anyway, so typically, propranolol is probably the most common one you end up seeing being used there. Atenolol could be an option though if they say, for instance, had asthma, so it could be a backup in those cases there. Let your patients know to try it out beforehand, right? You don't want them to try it the first time right before the event and all of a sudden their heart rate's like in the 40s. They may not be able to perform real well in those instances there. So have them try it out, take a test dose, and then typically 1 hour before the performance, go ahead and take the medication, and it should be in the system enough to cause the positive effects there. So again, typically for urgent issues of anxiety, start out with a benzo, typically for short course, maybe 2 to 4 weeks or so, and then start them out on the SSRI or maybe an SNRI therapy. Again, depending on how they respond to it. Some people get worse in anxiety with the SNRIs, they do okay with SSRIs, and vice versa. For non-urgent symptoms, though, you can start out with just an SSRI. It may not need a benzo in those instances. And then if they're not responding to it, just like we treat for depression, you try out something else, right? So you kind of switch it within class, and that's totally appropriate there. If they're still not responding, then you can consider a TCA, but we'd like to avoid those if we can based off side effect profiles, right? So those are the biggest things. Obviously, non-pharmacologic management as well, helping them to deal with their anxiety, learning for coping strategies, things like that all can be really useful and will be synergistic with your pharmacologic therapy. Any questions on anxiety? Yes, ma'am.
If we wanted like non-urgent but PRN, would we still go with a benzo versus SSRI?
What do you think?
Yeah.
Yeah, right, because again, benzos, they work immediately, right? SSRIs are going to take weeks to work. So yeah, that would typically be a thing where if you're like, maybe they're not like kind of constantly always anxious, but they're like, they're every couple, maybe a couple times a week or something, and, just get that feeling. They may be on the PRN benzo, right? It could be an option there for those patients, and it will work, relatively quickly as compared to the SSRIs for sure. Any other questions? Okay, moving on. I think this is the last section here. We talk about ADHD. This is the fun one because what do we get to talk about?
Drugs.
Meth. Basically, I mean, get to give people speed for a living. I mean, that's pretty interesting, right? I always think about Breaking Bad anytime I'm talking about ADHD meds. Kicking crystal meth, this stuff here. There's a lot of parallels there. And in fact, actually, watching Breaking Bad, they are very scientifically accurate in a lot of things. So, for instance, in the first episode, there's a red phosphorus exposure, and that's toxicologically exactly how that drug works, right? Or if you wanted to melt down a body with hydrofluoric acid, that's exactly what would happen, right? So, kudos to them for making an accurate show. Anyway, so typically when you have these kids with ADHD, and even some adults, because we're starting to see more patients either that have grown up with ADHD or they may have an adult diagnosis, typically you need to kind of figure out what kind of goals you want to shoot for. So do I just want them to be able to sit in their seat for 20 minutes? Do I need them to be able to complete their homework? What are the goals here, right? Typically, you want to go with your non-pharm therapy. Ideally, that'd be great because are there any drawbacks to using amphetamines? Yes, there are, right? So they can be addictive, right? Just like crystal meth is addictive, so can any of these amphetamines be. And so that, and make sure you have consistent kind of behavioral care. You don't want to have, maybe especially if parents are divorced and they get treated one way at one house and then the other house they get treated a totally different way. That can be difficult in order to kind of maintain some consistency there. Typically for management here, our stimulants are going to be our first line, and these are all going to fall under the amphetamine class. What schedule do you think that falls under? 2. All these are going to be C2. We'll talk about non-controlled substance as an alternative a little bit later on, some options there. But typically, most of these are going to be amphetamine-based. How do those work? Well, in some part, they have kind of a few mechanisms, some of which include things like blocking monoamine oxidase, right? They don't have that same irreversible sort of effect as something like phenazine would, but they do block it to some degree, which can lead to, increase in levels of serotonin and norepinephrine. They can help to block reuptake of things like dopamine and norepi. You start to see where the addictive properties come from, right? Blocking reuptake of dopamine in that cortical pathway, you can end up seeing that reward pathway being excited there, right? And then amphetamines themselves can actually stimulate release of catecholamines. They kind of do several different things there, blocking the reuptake, blocking metabolism, and directly causing them to be released, all of which can lead to that kind of that increase in focus you see there. And so I was looking online, and I was reading one time that someone was talking about how does it make sense that you give a stimulant to somebody who's already hyper excitable and they can't pay attention to anything? How does that even work, right? Because it sounds kind of counterintuitive, right? A little bit. And so someone actually gave a really good analogy, which I kind of liked, and it said imagine you're driving a car down the road, right? And do you see everything, but do you necessarily pay attention to every single thing that's on the side of the road? Only things that could be dangerous, right? Well, they said some of the ADHD is almost like you just pay attention to every single thing, and so you're so distracted that it's really hard to kind of focus on any one thing in particular in front of you. By giving the amphetamine, you kind of help to raise up those barriers a little bit, so you can kind of ignore that stuff and focus on just kind of what's ahead of you and what's really important at that moment. So I kind of like that analogy a little bit. Because again, having ADHD can be kind of exhausting and just trying to focus on any one thing, and it just helps to allow them to focus a little bit better. Doesn't work for everyone. I had one time when I was in college, in undergrad, I had this A&P lab. Ever told this story before? Probably not. But I was in this A&P lab, and it was like where you had to like dissect a cat. And so we had the final 8 o'clock lab. Final was coming up, and we had basically like you walk into the room, it looked like a movie from scene from Saw or something. There was just like dead cats everywhere, and you had to go through and like identify all the different parts on the cat. I had a friend who's taking the class with me, and so he, being an undergrad, sometimes you don't make the best decisions for yourself, and so he decided to stay up really late with a girl he had just met and not study like he should have. And it was like 2 a.m., and he's like, boy, I should really study for that thing. Maybe I'll take half an Adderall that I got from a buddy. So he ends up taking half an Adderall, and then he ends up, and here's what I hear at 7:45 at my door. I was like, what's going on? I get there, and he is just way too overexcitable. He's just having like flight of thoughts. He can't concentrate on anything. He's just like way too over. He's like ramped up to 12, right? So needless to say, when he actually got into the room and he had to sit there and be like, okay, is it this muscle or is it this thing? Do you think he was able to focus? No. So he ended up failing that lab and having to like repeat the whole thing. So I said, well, don't do drugs, right? That would not prescribe to you. So anyway, so there can be some drawbacks to these for sure. Anyway, so again, just because a patient does fail one of these doesn't mean they may not respond to another. So again, there can be some interpatient variability. If they're on dexmethylphenidate versus dextroamphetamine, they can have totally different responses there. Most of these tend to come in an extended release preparation. Why do you think that is? Yeah, I can take it in the morning, go to school, do whatever I need to do. By the time evening time comes around, drugs should be wearing off, so hopefully I can go to bed and be able to go to sleep, right? Also, if you think about it, this is a controlled substance. If you have to send your kid to school, typically they have to like hold on to the medication, they have to go to the nurse and get it. It's really disruptive to their day. So we don't use as often IR products, but certainly extended release is the more common one. And so here's a list of different ones we have here. Things like methylphenidate, you'll find they have a lot of different brand names depending on maybe like the dosage form or depending on different features there, if it's extended release or IR. So you'll hear a lot of different brand names associated with these. So for instance, like Quilivant is like a liquid preparation for really young kids who can't take tablets, right? We also have things like patches, which are handy because they provide a nice consistent amount of drug throughout a period of time versus taking a tablet, which is going to be a little bit more kind of a peak dose effect and then a big trough. We have things like dexmethylphenidate. We have some mixed amphetamine salts. This is our Adderall, kind of like the classic one you think about. This is a mixture of amphetamine and dextroamphetamine. And then finally we have lisdexamphetamine or Vyvanse. And so this is actually a prodrug. You did not know. Actually, once taken orally, it go through the liver and get converted over to dextroamphetamine, where it will then work just as similar as all these other drugs will. Anyone know why they did that? So how would people abuse stimulants? They could snort it, right? So one of the things you'll find patients may do is they will crush up the Adderalls or different amphetamine salts, and they will then snort them, right? And crushing them does what to the extended release properties? It gets rid of them, basically. So that way they absorb all that drug all at the same time. You get a really intense high off of that. And so they said, well, what if we had a drug here that was a prodrug, such that if you were to crush and snort this, is it going to be all that effective? Not really, because it's not active. It has to go through the liver first, and we know that nasal absorption bypasses the liver. So the idea was to try to help to deter abuse. If you take it orally, it works normally. If you take it any other route, it will not work nearly as well. That was the goal. However, I see a ton of kids are on this regardless, even though they don't have a risk for abuse, because again, it's a really good drug anyway. So I see a lot of patients who happen to be on Vyvanse who may not be a risk potential, but certainly that's initially why they developed it that way. Again, these are all C2s, so can you write, say for instance, any refills on these scripts? You cannot, right? C2s you can't write any refills on. What's the maximum number of days you can prescribe at a given time? 90, right? So you could write one script for 90 days. Or you could say write 3 scripts. This is more common. What I would see is they would write 3 scripts where they would say, okay, this one you would fill on today. The next one, say, do not fill until a month from then. And then the last one, say, do not fill until whatever that date would be, 2 months from then. The idea is you don't have to come back and come get a new script every single month. You may do that initially just to see how the patient's responding and see if you need to switch it up or change the dose or whatever. But once they are stable, then you can write them out for a longer period of time. So it would not be uncommon to where these patients would show up at the pharmacy. They would have 3 different scripts. We'd let them hold on to the other 2 because we don't want to like accidentally lose them or something would happen because then we're in trouble. So we let the parents keep that, and then we would just take the first one, fill it as normal, and then they'd come back in the next month and do their thing, right? So again, those are going to be the restrictions on that as being a C2, so pretty well controlled. In terms of side effects, as you might imagine, it being a stimulant, you're going to see this sort of effects that are similar to that. So for instance, they can have like reduced appetite. Any kind of stimulant, like cocaine, amphetamines, any of these things will reduce appetite and typically lead to weight loss, right? Is that great in growing kids? Not necessarily, right? So it's one thing you want to monitor for. Certainly insomnia can be a big one, especially if the dose they're getting is too high, or maybe they get like an afternoon dose. That is something we'll talk about with some management for in just a little bit. And again, tachycardia, hypertension, these are all things you'd expect to see just due to the fact that all these catecholamines are flooding the system. The sympathetic nervous system is overstimulated, and you will see that for sure. There are some black box warnings. I'm sure people have heard of horror stories of people on amphetamines having these like hallucinations and becoming violent and things like that. They can happen. They're rare, but it's something to at least be watchful for. The kid's just not acting right, or the adult's not acting right. That is something could be a warning sign and related to these stimulants. Dependence is also going to be a thing as well. Now, how would you expect, so like someone's on a benzo chronically and they come off of it acute, say cold turkey, how does that withdrawal look? Are they really sedate, or are they going to be kind of hyperexcitable? They're going to be anxious, and they're going to be sweating, and they're going to be tremulous, all that, right? Because again, they're on a depressant. You remove that, they're going to get overstimulated, right? Because again, their body reaches that new homeostasis, and they're used to having all that GABA effect around. Someone who's on a stimulant chronically, and you remove that cold turkey, how does that look, do you think? They kind of get really sedated, because again, they don't have that, all that catecholamines are flowing out there, so they may be kind of slow and just not have a lot of energy. Again, not particularly dangerous, but it may not be a great feeling for the patient to lose all of that sort of stimulant sort of effect there. So little things to think about. This can cause actual addiction in some cases, especially because it is helping to release that extra dopamine and that reward pathway. So just like any other illicit substance, opioids, cocaine, anything like that, they can certainly cause actual physical addiction. And again, avoid these if they have a history of substance abuse for sure, because again, this is just going to potentially lead them down a bad path. I mean, it's not uncommon that patients may get scripts for these, sell them in order to get money for whatever drug they do happen to have an addiction to. That's another thing you may see with some regularity. And then the other big concern you would think about, at least with kids, is that growth stunting, right? So again, it could be related to nutrition, could be related to some other features there. Typically though, do you keep these kids on ADHD meds year round? Not necessarily. Like, do they need it in the summertime when they're not in school? Maybe not, right? It just depends on kind of the child's unique case there. Frequently, we'll get in, we'll have kids that will get admitted to the hospital, and they'll have one of these ADHD meds on their profile, and the provider will go through and just reorder all their home meds. But the question is, like, okay, well, does the kid really still need their ADHD meds while they're in the hospital? And so that's a conversation we have with the docs and providers to see, like, okay, well, is it really necessary? Could it be exacerbating the reason why they're here in the first place? We like to see, does it really necessary to continue that medication or not? So drug-free periods tend to be helpful, and again, they help to mitigate some of that kind of long-term kind of chronic effects you see. In terms of non-stimulants, and again, I'll let you guys go on a break in just a little bit, but I want to finish this out. We have some non-stimulant ones. So here's an example of one called atomoxetine or Strattera. This is actually just an SNRI. It doesn't carry any indications for depression, but we will see this being used for ADHD specifically. And this is really the first one we used for adults for a long time before more people kind of were getting comfortable, with adult ADHD and prescribing amphetamines. This one will certainly, just like other antidepressants, will have a slower onset of action, so a few weeks, versus if I take an Adderall right now, the effects are going to be immediate or slow. Pretty immediate, right? You're going to be able to experience that effect fairly quickly as compared to a few weeks for something like Strattera. Nice thing, there's no abuse potential, so there's not a controlled substance, there's no issues with prescribing it. You can write for a whole year's worth, and you have no issues there, okay? Due to the SNRI effects, so you'd expect to see similar effects to like duloxetine or venlafaxine, hypertension, tachycardia, and again, suicidal ideation is also a risk here as well, right? So again, you gotta be watchful for that. Now on the other side though, let's say we can go with something that kind of helps to tamp down the sympathetic nervous system and kind of chill out the patient a little bit. We can actually use some alpha-2 agonists, and we've talked about one of these before, I think both of these actually, back when we were talking about hypertension. And so we have two here. We're going to talk about guanfacine and clonidine. I know we definitely talked about clonidine, right? And remember, basically by activating those autoreceptors on the presynaptic neurons, you decrease the amount of catecholamines being released, and that helps to kind of chill the patient out a little bit, maybe helps them to focus a little bit better. Now, would it make sense to give clonidine at the same time as an amphetamine? No, because they have completely opposite actions. One's meant to decrease catecholamine release, the other one is directly stimulating catecholamine release. Doesn't make sense. Sometimes you may find patients will be on this as monotherapy. Maybe they couldn't tolerate the amphetamines, maybe that a contraindication to it. You can use this as an alternative potentially. Or what I will sometimes see is that kids will be on, say, an amphetamine in the morning time, and they may be dosing this at nighttime to help them get to sleep. So maybe they have some residual insomnia, something like that. This can help out with that, okay? So again, I don't necessarily like to treat the side effects of drugs with more drugs, but sometimes that is the best compromise there. Again, sedation is the most common side effect you're going to see with these two. And then you can see some hypotension and constipation as well. Because again, you're just kind of slowing everything down a little bit. And so that's pretty common things you would see. Again, therapy has to be personalized, so looking at things like how we're going to dose it, dosing strategies, dosing frequencies, things like that. Again, look at comorbid conditions. As adults are getting more and more frequently being prescribed these medications, like, does it make sense to give a guy with hypertension amphetamines? Probably not, right, unless you can get that under control. So things you can think about. Typically, stimulants will be first line unless they're contraindicated, and then something like Strattera might be a good backup agent there, and then you can consider something like, like clonidine or guanfacine in that kind of same vein, and so just see how they respond to it, right? And again, maybe consider antidepressant therapy, especially if they have any degree of depression or anxiety that could be actually worsening the ADHD. Again, these may be comorbid conditions. Any questions on that section? And I've thoroughly sedated majority of you. Let's take a 10-minute break and we'll come back and then get on the next section. At what age is it appropriate to medicate a child for ADHD? I wanted to give my kid some guanfacine yesterday. Get her asleep. I don't know. That's a tough one. It's probably very individualized because it's hard to say like what's a kid being a kid versus what's like legit ADHD. So you guys get a lot more on the diagnosis aspect of it with Professor Austin. So she might be a better person to ask, or someone who actually works in peds and prescribes these drugs. I couldn't say. I've certainly seen pretty young kids on it. I mean, certainly down to like, I don't know if I've seen a 5-year-old, but certainly 6 is, pretty, with some current regularity, I would say, yeah. I don't know if I have a perfect answer for that. Have you heard of college students that overdose on Adderall and have a seizure because of it? Mm-hmm. I've heard a lot of people taking too much Adderall or other amphetamines and seizing because of it. So yeah, you just overstimulate the system and then boom, all of a sudden, you can definitely have a seizure. How would you treat that? Benzos, yeah. Benzos, always for drug-induced seizures, go with benzos. We'll talk about some other meds you could use as an alternative, perhaps. But, these seizures may not always actually be due to the mechanism of what you think. So I'll give you an example. So sort of a cousin of the amphetamines, sort of in the same chemical structure, but acts a little differently, would be MDMA, right? Anyone know another name for that? Molly or ecstasy, right? That one actually has a lot more serotonergic effect, right? So if you think about someone who's taking MDMA, they're probably not looking to fight anyone. They probably want to like hug people more than anything else due to some of the serotonergic effects. What's interesting though is that one of the things you'll see with amphetamine use is they kind of have this like need to do like repetitive movements or repetitive actions over and over again. And then also MDMA can cause SIADH, right? So what happens is these patients will all of a sudden have this like kind of increased thirst response, and then all of a sudden they're just chugging down tons and tons of water. They have all this extra ADH around, and guess what happens? They get very hyponatremic and actually end up seizing from that. So I've seen a couple cases actually have led to death where the patients are coming in, their sodium's like 115 or something related to this. Not common, but it's something that can occur. And again, how would you treat a seizure due to hyponatremia versus just due to kind of overstimulation of the CNS? At that point, you give them sodium, right? So, but sometimes you may not know what it is, right? So, patients coming in, unknown drug exposure, they're seizing. You're going to give them benzos anyway because you treat it as a seizure until proven otherwise. But then you get your basic metabolic panel back, or you get your ABG back that has lights on it, and then boom, you see their sodium's like 110, and then okay, well, how do I treat that? Sodium, yeah. So I use a hypertonic saline or something would be good to actually help raise that sodium up. So for instance, I may use like a 3% sodium chloride versus the 0.9% that's considered normal saline in order to get that up to stop the seizure. So if you're giving benzos and you're like, man, it's just not working, patient's still seizing, it could be related to their electrolytes, and hyponatremia is a common one, right? Anyway, do you need to taper stimulants to reduce sedation withdrawal effect? Is there any risk with abruptly discontinuing? I'm not aware of any actual dangerous things with abruptly discontinuing. It may be reasonable to consider tapering off if you wanted to. The problem though with a lot of those extended release preparations is that they you can't crush or chew them, so it's harder to titrate. It's not like I can just take half an Adderall in some cases, unless they're specifically designed for that. You end up breaking the extended release properties and they get the whole dose at one time. So not as common as you might think it would be. So, any other questions? We're going to start in the surgery section. So you guys have started surgery, right? Yeah, so we're going to focus on the meds. This is almost more like an anesthesiology section more than anything, because we, if you're actually talking about medications used in surgery, 9 times out of 10 they're going to be coming from the anesthesiology group, right? But you as PAs still need to be aware of the medications that they're using, the effects that may have on your patient. You may be prescribing some of these yourselves depending on the situation, whether it's, say before or after surgery. So we'll talk about some different cases there. But let us talk about the ether bunny. Isn't that cute? Oh, it's a little. My dad's a CRNA, so I have a particular what I'm thinking of. Predilection for. There's a different word I was thinking. Not predilection, but there's a different one. I'll think of it later. But regardless, my dad's a CRNA, and so we actually gave him. There's a Far Side. You guys know the Far Side comics? Yeah, Gary Larson. Yeah, good. There's one with the ether bunny that was on there, and he's like, putting gas on the patient and everything. Thought that was pretty cute. But anyway, so when I say anesthesia, what does that mean?
No pain.
No pain. Patients, are they at a raised level of consciousness? No, they're pretty sedated. They may be completely unconscious, right? They may be unconscious to the point where they would not be breathing at all, and so we have to take over for that for them. And you're going to see there's a lot of gradations there. There's things like conscious sedations, there's deep sedation, light sedation. We'll talk about all the differences there. Some basic definitions we'll get into. When we talk about balanced anesthesia, this basically means using a mixture of medications, both from, say, an inhaled standpoint, so things like general anesthesia, where you can give a gas to the patient as they inhale that. We'll see how that gets into the CNS to cause pretty much general, just blanket sedation for the patient. And then also IV medications to help induce that. And we'll look at how they kind of work well together in those cases. When I say inhalational anesthesia, it just means it's something you breathe in. Anyone know any examples of inhalational anesthetic agents? Laughing gas. What is laughing gas? Nitrous or nitric oxide? Nitrous oxide, right? So nitrous oxide. Nitric oxide is actually used for pulmonary hypertension, or used in some really sick critical care patients to help with their ventilation. But nitrous oxide is what we'd use as laughing gas, essentially for as a more of a light sort of sedation there. There's lots of other ones we'll mention here as well. When I say minimum alveolar anesthetic concentration, or the MAC, all that's really referring to is saying how much of that gas you have to get into the actual alveoli at a concentration, such that you would get basically a lack of response to a painful stimuli in 50% of patients. Now again, if you're going to surgery, you want a 50% chance that you're not going to feel that scalpel cutting into your abdomen. I wouldn't like those chances. But again, it serves as a nice way to compare different medications together. Just like remember back in pharmacodynamics, we talked about ED50s and TD50s. This is kind of a similar concept, right? So by comparing the MACs together, you can see how potent the agent is. Do I need a lot of drug in order to get that a patient to not respond to that stimulus, or do I just need a little bit? Because again, for every molecule of anesthetic gas I'm putting into the patient, what's one molecule less I'm getting of? Oxygen, right? So again, there's a balance there. You still need to oxygenate the patient. So you need to make sure they're still getting oxygen. We don't have to give so much drug to pass them out that they are going to become hypoxic, right? When I say analgesia, it just means obviously a decreased awareness or sensation of pain. And then when I say general anesthesia, it basically means where you just kind of put the patient completely unconscious, essentially. Typically, there's going to be relaxation of the skeletal muscle will happen here. They'll lose their reflexes, because you want your patient moving around when they're under surgery. There'll typically be amnesia associated with this, so if they're not going to remember any of the features there. And so basically this anesthesia is that state that is induced by our general anesthetics, right? And again, depending on the situation, you may just want to have a light sedation, say if you're like reducing a dislocated joint, all the way up to general anesthesia for someone who needs to have, say, abdominal surgery or something like that. And so you're going to find that depending on what kind of sedation we want, what kind of patients we have in terms of comorbid conditions and things like that, it will help us to decide what kind of drugs we want to use, what routes we want to use, and how to use them essentially. So when I'm saying amnesia, what does that mean? No, I'm really asking. I don't remember. I forgot. No. Right, so basically in these cases here, it will include like this kind of abolition of sensation, right? So they will not remember that they had pain. They may have felt the pain at the moment, but they will kind of forget about that pain there. They'll be unaware of that situation. Now I say retrograde amnesia versus anterograde, what's the difference? Antero means
Forward.
things going forward versus retrograde. So like alcohol, for instance, would provide what kind of anesthesia, or what kind of amnesia? It's more anterograde actually, right? Because you remember everything you did up to that night when you went out drinking, right? Do you remember what happened afterwards? Maybe not. Hopefully you do, because you're responsible drinkers or not drinkers at all. But at least not in school. You guys will never do that, right? Good, I have you on tape. But anyway, so you'll end up seeing here that, you know, when they have the sedation, it just means, again, just decrease in activity, alertness, arousal, vigilance, you know, so they'll be basically not really responding to a whole lot of external stimuli in a lot of cases there. Now again, just because we'll have some agents that will be better as amnestics, meaning that patients may be experiencing a lot of pain, but they may not remember it after the fact, which can be beneficial, versus analgesic agents that actually don't provide any amnestic properties. They just deal with the actual sensation of pain. And frequently use the two together. So for instance, we've already mentioned several of these. If I have a patient who comes into the ER and they have an obviously displaced fracture, say of their forearm, we probably want to give them an analgesic to deal with that acute pain that they're screaming about, but also an amnestic to help them kind of forget some of the details, right? So that way they're a little fuzzy on it, help to decrease some of that maybe potentially traumatic experience. And so we may use something like a fentanyl from an analgesic standpoint, and then use something like a Versed or midazolam from an amnestic standpoint, right? So again, these different medications will provide different roles based on their mechanism and their actions. So, like I mentioned, with the balanced anesthesia, we're going to be utilizing both the kinetics and the dynamics of these different drugs to work together in synergy to make sure we provide a nice balanced sort of anesthetic property. And again, ideally, you'd want this to be a very rapid process, right? So you can rapidly induce anesthesia. You can have this rapid loss of consciousness. They will allow for them to be relatively physiologically stable during that period, have a wide safety margin, obviously, and then we'd like to be able to bring them back out of it quickly as well, right? And we'll see that depending on the agent we're using, that may not be possible. They'll have different, durations of action, etc. Ideally, we'd like to have them be devoid of adverse effects, but do any medications fit all of these points? Not yet, right? So we don't have anything like that. So typically you'll see with our choice of anesthetics, it can vary depending on the type of procedure that you're going to do. So for instance, say you have like a minor procedure, maybe like a dental procedure or something like that, maybe just an oral or parenteral sedative may be appropriate, right? Maybe just a little bit of oral or IV Versed might be a good option for those patients there. Or maybe local anesthetics can be also used as well. We'll talk about those later. And again, what's the benefit of using a local anesthetic? Well, I don't feel the pain at all because the whole area is numbed up, right? Remember we talked about like peripheral nerve blocks, we talked about epidurals and things like that. Even local infiltration of a local anesthetic into the site can be beneficial to help reduce a lot of that pain patients will experience. Doesn't provide analgesic effect, they just don't get the sensation at all, right? For more major procedures, this is where we're going to be using both inhalational and IV therapy, to where we may say give them a preoperative dose of a benzodiazepine, so maybe either oral or IV benzo. So frequently, like I'll see these patients, orders come through in the pharmacy, and again working like the 6 a.m. shift, so usually like 7, 8 o'clock I get all the anesthesia orders coming in for the morning's patients, and typically they'll get Versed before they go into surgery, because again, are people nervous when they go for surgery a lot of times? Yeah, so it's an anxiolytic, so it'll chill them out a little bit. They'll kind of start that amnestic sort of properties there. We also typically give them a dose of Tylenol. May not always be the case in the adult realm, but the Tylenol does what for us? Opioid sparing provides some additional analgesic sort of effect there, so they'll get that beforehand. And they'll typically get an IV anesthetic agent in order to induce that anesthesia, and then we'll end up using usually either inhaled or IV anesthetics to keep them asleep. Because you want your patients waking up in the middle of surgery? Typically, no. I remember one time when I was getting my wisdom teeth removed as a child. I wasn't like really aware of like all the things that were happening, but now that I think back, I remember a few details. And I remember when I had to have them all cut out because I was pretty young when it happened. So I did get some. I believe I got a little bit of nitrous at first, to kind of get me like kind of chilled out a little bit. And then I remember there's a white substance that was hanging up from an IV pole. Anyone know what that is? Yeah, propofol. We'll talk about that a little bit later. But I clearly remember, I was like, what's that milk doing up there? But that was for me. That was my milk to make me sleepy. But I remember kind of waking up partway through, and they're just like, it looks like he's awake. And they hit a button, and I was like, back out. So. But again, that was a much lighter sort of anesthesia than if I was saying getting my abdomen cut open, right? So again, there's going to be a lot of areas of gray here. But we'll talk about the different types, inhalational versus intravenous. Again, when you're thinking about like an actual like surgical suite kind of thing, you're thinking a lot of inhalational agents. If you're thinking more like procedural based, say for instance, like you're in the ER, we don't really use a lot of inhalational anesthetics. We typically stick with more oral or IV sort of agents there. So we'll talk about the different clinical situations where you might use one versus the other. So the inhaled anesthetics, these are volatile liquids, right? So they come in containers as liquids, but then we will aerosolize them and allow for the patients to inhale them. The most commonly used ones would be isoflurane, desflurane, sevoflurane. These are useful for helping to maintain general anesthesia during surgery. And then we'll have nitrous oxide as well. This is going to be much wimpier in terms of its actions as a sedative, but is nice for sort of like lighter procedures, things like that. And so there may be some use cases for it, and we'll look at that in a moment. In terms of IV anesthetics, we're going to use our barbiturates can come into play here. We'll see occasionally. We'll see a lot of benzodiazepines being used. We'll see a lot of propofol. Go through a ton of propofol in the surgical realm. We'll see ketamine, opioids, and we'll look at some other agents, some other ancillary things that can kind of help us out. So looking at, again, at the balanced anesthesia, typically we'll use what we call induction agents, or we use IV agents to rapidly knock the patient out, essentially, get them unconscious. Typically, at this point, this is also where you're going to be considering like intubating the patient if they're going to go under general anesthesia, because they will lose that ability to breathe on their own. We'll talk about some of the physiologic effects we'll see in a moment. And then that's when we can start up the inhalational anesthesia, and that's going to help to maintain them at that level of consciousness, right? And so you'll find that during that maintenance phase, we'll also maybe using some IV anesthetics as well. Sometimes it depends on the type of surgery. If it's particularly invasive, you may need more or less depending on what you're doing there. And then frequently we'll do a lot of local blocks and spinal blocks and things like that, and again to help kind of mitigate that transmission of those painful signals. And we'll talk more in depth about the anesthetics, local anesthetics later on. So there's several stages of anesthesia here, and have you covered this with Professor Gardner, right? Okay, so there's kind of 4 different stages here, and we'll find that some of them are more preferable than others depending on kind of what we're shooting for. It's just kind of the first stage of analgesia, the stage of excitement. Does that sound good for the surgical realm? Probably not. You don't want to stay in this one for too long, as we'll see. There's that state of surgical anesthesia. It's probably going to be the sweet spot for a lot of patients. And then there's like complete like medullary depression. Basically, you just have like a corpse you're working on, right? Sort of. But we'll look at some different cases here, right? So anyway, with the first stage of analgesia here, basically the patient may not have a whole lot of amnestic sort of properties going on at this point. They will definitely have some analgesia. So imagine getting a dose of fentanyl. It'll provide good analgesia. You may remember all the details of what was going on though at the time, right? Typically, as you get kind of further along the gradation towards the end of stage 1 before stage 2, you're going to find then some more amnestic properties are going to be there. So say instead of just getting a dose of fentanyl, also got a dose of Versed to go along with that, right? Midazolam, a benzodiazepine will help provide some of the extra amnesia at that point. At the stage of excitement, this is where the patient may be seeming like they're conscious and may be vocalizing things, but they're not really there for the most part. So the patient's definitely amnestic. They're not going to remember what was going on. They'll be like, hey, remember that stuff you said? And they'll be like, nope. That's kind of the stage they're at this point here. This is also where physiologically speaking, things get a little sort of labile, right? So you may find that the respiration may not be regular in terms of both rate and volume. It may be a little bit more sporadic in terms of that. Patients tend to be more likely to vomit in this state. Now, what is a risk for patient vomiting under anesthesia? Aspiration, right? So that's another big thing you're going to see is using antiemetic drugs in order to help prevent them from vomiting. Now, if you're intubated, are you kind of protected from aspirating? You kind of are, right? So again, there's cuffs that will inflate in order to make sure that even if you did vomit, that would not occur. You typically see patients will vomit in the middle of surgery. It's typically in the post-anesthesia sort of setting. They're kind of waking up is when a lot of that happens, but we'll talk more about that a little bit later. And then again, for the most part, you're going to have efforts to not stay in the stage for very long, or you can try to blow right past it or stay right above it, depending on what you kind of need at that point. After that is when you start to get more regular establishment of breathing at that point. When you're at surgical anesthesia, then you're going to see maybe some more regular respirations, and this actually gets broken up into a couple of different planes, because as it extends towards the end of later planes of stage 3, and I'll show you a picture of this so it will make more sense in a little bit. This is where you will actually develop the apnea, right? So this is where we need to make sure the patients are intubated on the ventilator so we can breathe for them at that point. And then finally, this deepest stage here, so I kind of think about like, you guys watch that movie Inception? Kind of like when you go like 4 levels down, like this is like, the medullary depression stage, so I always thought it was cool to go to that chemist. And he's like, oh yeah, I went ahead and I concocted this thing that provides a super deep anesthesia, but your vestibular apparatus still works. That way we can wake you back up, and all that stuff is cool. But basically here you're going to find that this is where actually the CNS is going to be severely depressed at this point. This is where things like vasomotor instability can occur here, respiratory instability can happen. And basically without providing them support, usually some sort of circulatory respiratory support, the patient would just die, right? So looking at this, you can kind of see different features here in terms of things like ocular movement, pupil size, how that can actually respond during surgery. Bigger things I think about, it includes things like respirations, muscle tone is also a really big one, because like, do you want your patients to be all tensed up and struggling during surgery? You want them to be pretty well relaxed. And we'll also talk about some paralytic agents a little bit later in this section too that can be useful as well. Paralytics are frequently used in order to make sure all the muscles are nice and loose, so that way you can cut through them and do what you need to do in order to do the surgery. But you notice here that in stage 1, patient may have normal breathing. This may be a level of say like a procedural sedation, where it's typically fairly light in terms of the meds. They can still breathe on their own. You may still have like a respiratory tech person there who's still watching the patient just in case they slip down a little bit deeper, but that can be useful. And then as you get to that level of excitement, we like to avoid this because again, it's kind of very labile from a respiratory standpoint. And then we get down into surgical anesthesia. This is where most of your patients will probably end up while they're in the middle of surgery for the most part. Okay, kind of makes sense? Maybe, maybe not. It's okay. Here's just some other ways to look at it too. So again, looking at kind of like their behavior, respiratory rate, things like that. Again, I'm not going to quiz you specifically and say like on plane 2 of stage 3, what's the respiratory rate? I don't really care if you know that specific. You may need to know for other classes, not for me though. But I just kind of want to give you an idea of kind of like where we're taking the patients to with our medications and kind of what physiologic effects you could expect to see. Okay, so getting into the inhaled anesthetics, these are going to, again, be these gases or vapors we're going to be providing, usually through the ventilatory circuit as the patient's getting intubated. And it's going to find that based on the pressure, the partial pressure of the inhaled anesthetic, you can kind of change your dose. So by increasing the amount of gases being inhaled, the partial pressure is going to go up, and that provides more sedative effects, essentially. Some other things that will affect how well these medications work include things like the blood-to-gas partition coefficient. So again, how well the gas will actually partition out of the alveoli into the blood itself. If that's a very slow process, then or not very extensive, then you may need more gas in order to get the same anesthetic properties, right? That may change what that MAC is, or that minimum alveolar concentration, right? Because ideally, where are these drugs working at? In the brain, right? Because again, you're trying to sedate the patient enough to where you can do surgery. So, and again, do things inhaled from the lungs get to the brain pretty quick? They do, right? If you think about blood flow coming through the lungs, where does it go to after the lungs? Left side of the heart, and then where does it go from there? Straight up to the brain, right? So again, it's a very fast way to get medications up to the CNS. If you don't believe me, check out patients who abuse cocaine. Look at IV cocaine versus, say, crack cocaine, which you inhale, works much faster. It's actually more addicting than strict IV or, say, nasally insufflated cocaine. You guys know that term, insufflation? If you snort something, that's what that means, right? Not necessarily. Usually with these medications here, we like them to be lipophilic, so that way they can, one, get out of the lungs and into the blood, and then once they get up to the CNS, they can cross back over to the blood-brain barrier. But it may be dependent. IV to inhaled, it may be very drug dependent. So if I inhaled something that was not very lipophilic, then it would probably not really get to the brain in very high quantities, right? Versus something that is really lipophilic, yeah, it would certainly do that. So it could depend. But anyways, like I mentioned, these coefficients are important to consider when kind of comparing the drugs. Ultimately, what that means is that the doses will be different between the two based on their physicochemical properties. So So again, other things to look at these anesthetics here, how high of a concentration we get in the brain is going to be the solubility properties, as we kind of mentioned there, the concentration in the inspired air, so again, what the balance is between the O2 coming in and also the anesthetic, the volume of pulmonary ventilation. What do you think this would matter? Well, bigger volumes, you're inhaling more drug, you'd expect more effects, right? Pulmonary blood flow can also play a role here as well, because again, if the blood's not circulating well enough to pick up the drug, then it may not be able to get it to the brain as well. And then we'll look at that kind of partial pressure gradient between the arterial and the mixed venous blood at anesthetic concentration. So again, depending on that ratio between those two, that can actually help to enhance the drug to work a little faster. To give you some ideas of the anesthetic solubility, again, you're not going to have to memorize the slide here or anything, but looking at the actual anesthetic concentration or the percent of the inspired tension, and looking at this, you can see that, okay, well, this one doesn't really appear to be all that, or it has pretty rapid solubility early on, but notice it'll have a plateau effect at some point, right? And that would be dependent on each one there, depending on how soluble they are, whereas something like halothane not going to be as soluble as nitrous oxide. And you'll see that in terms of differences in how quickly it works. And the reason why, we don't use anesthetics, inhaled anesthetics to induce sleep for these patients, because again, they just don't typically work as fast as we would see with an IV agent. So typically how these are working is they're going to be working on those GABA A channels, right? So these are going to help to prevent those neurons from firing. And again, they can be pretty significant in terms of how severe they can prevent that firing from occurring. And again, you'll find that a lot of the IV anesthetic agents we're using as well kind of have similar properties additionally. So GABA A is going to be really the big player here in getting all those neurons hyperpolarized. All right, so I mentioned the typical ones you're going to run into are going to be nitrous oxide, things like halothane, enflurane, isoflurane, sevoflurane, and then desflurane. Typically, if you see a fluorine at the end of the name, you know it's going to be an inhaled anesthetic, but we have the one oddball, nitrous oxide here, right? So as I mentioned, that mean alveolar concentration there, you'll typically find that when you're using, again, you wouldn't want to have a 50% chance your drug's going to work for the patients. You're typically aiming above that. But if, say, for instance, you just went to, say, 1.3 times the MAC of the drug, that's enough to inhibit movement in patients in about 95% of them. So it's still pretty good, but you can probably even use higher doses than that in a lot of cases. The nice thing, too, with it being an inhaled drug that's kind of continuously going in, you can titrate your dose really well as well. So you'll find that typically the anesthesiologist or the CRNAs will be at the head of the bed. They're working with the ventilator. They can change on the fly how much gas they're actually inspiring in order to change the level of sedation they're experiencing there. Some patients who may have a decreased MAC, meaning they need less drug to get the same effects, included like the elderly. Actually, hypothermia also helps enhance the effects of the drugs here. Things that increase the MAC, maybe things like pregnancy, because they have different changes in blood volume status, alcohol abuse. Why do you think alcohol abuse would make these drugs not work as well and require more? Well, they're chronically used to having that extra GABA A activity anyway, that they're, again, very tolerant to those effects. They would need even more drug in order to get the same thing there, right? Or if they use other centrally acting medications, it could also enhance that. So if they're chronically on benzos, they may need more gas in order to help maintain that sedation there. Actually, what you end up finding, though, is that sex, height, and weight don't actually play a big role here, mainly because depending on the percentage of gas that you're giving there and based on their lung volume and all of that, like, it actually doesn't have a big effect. Because so, someone who is, say, a child versus an adult patient, it's all relative in terms of their lung volumes and their size of the patient, how much they're getting. So again, you can titrate it too. So if they're too sedate, you give them a little less. If they're not sedate enough, then you give them some more. And so looking at this again, you can see how much you have to give in order to get things like immobility or versus unconsciousness. The lower side of things, you're going to get maybe some amnesia, but certainly here for like general surgery, like, yeah, you want to get up into this category here. We get towards immobility. The patient's not going to be moving on you, so the surgeon can do their thing. So other effects you're going to find with these medications here can vary. So again, it'd be nice if they just affected the brain, but typically they will have some other cardiovascular effects as well. Typically, respiratory function you expect to be diminished, right, which makes sense because they're going to get apneic from this because they're suppressing everything. We'll find they actually have some pretty variable effects on the cardiovascular system. Some will cause tachycardia, some cause bradycardia. I'll show you a table that will compare that just a little bit later on. Typically, they're having kind of a decreased metabolic rate overall and maybe decreased blood flow to the organs like the kidneys and the liver potentially. This can affect in the short term how they're processing drugs, but clinically it doesn't come up all that often. So getting into the different agents here, we'll start off with halothane. Now, we used to use, anyone know what, like, the really old school one we used to use was with that bunny earlier? Ether, yeah, I used to use ether. Anyone know why we don't use that stuff anymore? It's highly flammable. Like it would actually is a risk for like causing actually like explosions and stuff like in surgical suites. So they ever watched that movie Cider House Rules? No, it's actually a pretty good movie. But one of the docs in that movie, he's actually addicted to ether, and so he'll kind of frequently use it to go to sleep. They used to have to actually put like electrical outlets above a certain line on the wall. It had to be so high up because that was like basically where the ether could not rise up any higher based on its kind of weight compared to or density compared to oxygen, and in order to prevent sparks from happening in an explosion. So it's kind of interesting thing you may see like in old school surgical pictures. But anyway, so we don't use that anymore. Nowadays we use halothane potentially. This is a pretty potent one. Again, activating the GABA A channels. All these are going to work through the same mechanism essentially. Typically, you're going to find, again, they have relatively slow onset as compared to your IV agents, meaning, again, they're not going to be used for induction of anesthesia, but just more maintenance of anesthesia there. You may find differences here in why we use additional drugs. So, for instance, it doesn't have a whole lot of analgesic properties, which is why we may use things like intraoperative opioids in order to provide some additional pain relief for those patients. That way they're not really conscious or aware of any of that. And again, how do these drugs get eliminated? Frequently just through the expired gas, right? So again, whenever they're not going to be absorbing, they'll just breathe right back out. Next we have enflurane, a little less potent than halothane, so may have to give a higher concentration in order to get the same effects there. Typically, you're going to find this one has a nice little bit more rapid onset than halothane, than something like than halothane would have there. And also, it's nice because typically, if it has a rapid onset, it will typically have a rapid offset as well. And what's the benefit of that? Patients wake up sooner, right? They wake up sooner and get them over the PACU. They can recover faster, and they can send them wherever they need to go, right? So they need to go home or go to go to an inpatient bed, wherever they need to do. Depending on the agent you're receiving here, again, they can actually do things like sensitize the heart to catecholamines, and so ventricular arrhythmias may be at risk. So, for instance, like halothane can see some arrhythmias. Enflurane, though, it has a lower incidence of that, which is also beneficial. Having an arrhythmia in the middle of surgery, not ideal, right? Other things you might see would be like hypotension that can develop. So sometimes you may find that anesthesiologists will have like, they call them like epi-spritzers, where they have like a little syringe full of low concentration epinephrine or phenylephrine. They can administer small bits to control the blood pressure. You may see that occasionally. And of course, certainly if you had a patient who was seizing that, this drug would certainly help to prevent that from occurring. So EEG changes would be kind of consistent with that. Next we have isoflurane. This one's nice. They like it because it's a little bit better in terms of like a muscle relaxant in order to help kind of make sure the patient's not tensing up any muscles at all. This one's kind of come around and kind of replaced a lot of use of enflurane and halothane for the most part, mainly because it offers a little bit more rapid induction there. And again, more rapid the induction, typically the faster the wake up process is. So that's kind of why we like to use this one. And as I mentioned on a previous slide, typically like desflurane, sevoflurane, and isoflurane are kind of the three most common ones I end up running into, at least from a surgical standpoint. This one's also nice because it doesn't really cause many arrhythmias. However, you're going to see the similar effects like the respiratory depression, hypotension can develop here, and that may cause sort of a reflex tachycardia, increasing that cardiac output. So maybe consider, if you have a patient with like a cardiovascular history, this may choose, if you're doing a cardiac surgery, this may lead you to picking one over the other based on these effects here. Desflurane, this one you may see used a little bit more frequently, like for outpatient surgeries. This one's not great from an induction standpoint, but has really rapid recovery, so like within 5 minutes or so. And especially for like an outpatient office, you want them to wake up pretty quick, or a surgical center, you want them to wake up so they can go home potentially. Here, again, you're going to find some myocardial depression, and then potentially one of the dangerous things when they're coming out of anesthesia would be laryngospasm. You know what that is? Because your vocal cords kind of tighten up, and what does that do to your ability to breathe? It's not great, right? So ultimately what we end up doing is actually giving these patients paralytics and more sedatives. Now we can re-intubate the patient. So it's another thing to be considerate of when they're coming out of surgery. So for instance, like in our ORs, we have laryngospasm kits. So that way, in case a patient's waking up and they develop that where they can't breathe, they get stridors, we can actually go and give them the kit. We'll paralyze them, give them sedative, and then intubate them again to make sure we can breathe for them until that laryngospasm sort of abates. Next we have sevoflurane. This one is going to have, again, pretty rapid onset and recovery. Here you may actually find some bradyarrhythmias that can develop, or tachyarrhythmias, so it can kind of go either way there. Again, hypotension is somewhat common depending on the dose that they're experiencing. Again, nausea vomiting is going to be a pretty common one with most of these drugs as they're waking up typically. And then we have N2O, or nitrous oxide, your laughing gas. Now I mentioned when I had my wisdom teeth taken out, they gave me some nitrous oxide. Do you know how they could? They did a test to see if it was working or not. You know what test they did? the new countdown. Because it's not really like, if I was getting like propofol, then that's like a kind of a countdown drug. It's like 10, 9, 8, like nitrous, you're still going to be conscious for it. So not nearly the same sort of level of sedation as you would see with like a sevoflurane or something like that. But however, the orthodontic surgeon, whoever he was, came in and he goes, okay, well, I need to see if the drug's working or not. So he says, okay, so Panda walks into a restaurant and he orders some food and he has a very nice meal, but then the waiter comes up and brings him the check. Panda pulls out a gun, shoots the waiter, and then runs out of the restaurant. And the guy at the bar looks at the bartender and says, what happened there? What's up with that panda? And the guy says, well, you gotta look at the definition of a panda. He looked it up and it says, panda, eats, shoots, leaves. And I thought that was so funny. I was laughing so hard. He said, yep, the stuff's working. It's great. Anyway, so this is definitely going to be much lighter in terms of the sedation this can induce, very much for more minor dental procedures or maybe kind of leading up to getting some other sedative agents there, so more of a supplement to more potent anesthetics. So I think in that case there I probably got some N2O and then they induced me with propofol to do the surgery, right? Again, incomplete anesthetic, this is not going to be the solo agent you're going to use unless it's a very minor procedure for the most part. And in fact, in order to get the same level of sedation as something like a sevoflurane, you'd have to give so much nitrous oxide that the patient would basically get no O2 and they could die from that, right? Another way to go unconscious is to basically take away the O2 as it turns out, right? Not good for your patient, so. So this one's kind of interesting because there are some unique side effects to N2O, and in fact, this is a common one that gets abused by either anesthesia providers or potentially dentists and things like that. They may actually abuse nitrous oxide for sort of CNS depressant effects. So things like hypotension can be relatively common with this one. Also kind of an interesting side effect here is it can expand the volume of gas in air cavities. Kind of a unique side effect there. So potentially that could actually cause like a rupture of a bowel if it was already distended. That's a pretty rare thing, but could potentially happen there. One thing you do want to be cautious of, it actually can cause a pernicious anemia, and this is something that may manifest for patients who are abusing it chronically, so they're not using it therapeutically, but abusing it. They can actually develop an anemia. It has to do, I believe, like folate synthesis or something, or folate utilization. They end up developing that. So other things to worry about, immunocompromised patients or immunosuppressed patients. This can have some effects on them in terms of the white blood cell production, kind of like with the anemia aspects of it. And then pregnant women do not do well with this one either. So kind of looking at this, and again, don't memorize these numbers here, but I kind of want to just give you an example of what kind of the comparisons between them. So for instance, looking at nitrous oxide, remember the minimum alveolar concentration to get 50% of people not responding to a painful stimulus is over 100 versus something like sevoflurane is only 2. So it goes to show you you'd have to give so much of this gas to get that kind of level that you'd be giving basically no oxygen whatsoever, right? For the most part, other things to look at are comparing sort of like the relative onset and offset of action, kind of get a feel for how we might use these different drugs together, or use one versus the other. In terms of their effects on the cardiovascular system, this is a good one I like to look at just to kind of remember. Most of them can have some effect on mean arterial pressure to some degree, right? Whether they go up or down, typically hypotension is going to be the more common thing you're going to run into. Typically, if it's causing a lot of hypotension, a lot of vasodilation, this is where cardiac output is going to be affected, typically going up in these cases here. Here's an example where you see the systemic vascular resistance is going to be affected, typically going down. So for instance here, desflurane being an option here. And then looking at the heart rate, typically, and I think the color's messed up on the, I'll post a corrected version, has an up or down. But typically halothane typically causes tachycardia versus just even bradycardia, more with like desflurane and isoflurane. So I'll put a correction for that one up. So just little things to consider. Now in terms of toxicity, not a ton as long as you're supporting them from a cardiovascular standpoint. The big one I would want to make mention of here is called malignant hyperthermia. Okay, I have a slide on that. Yes, I do. So basically this is going to be a genetic disorder that patients may be at risk for. Basically it has to do with this ryanodine receptor that is located in the skeletal muscle. Essentially what happens, and there's actually a paralytic we'll talk about a little bit later that can do this too, called succinylcholine. The succinylcholine in the inhaled anesthetics can cause this malignant hyperthermia, and we don't have a good way to test for it, or we don't test many patients for it unless they have maybe like a family history of bad reaction to anesthesia, right? They may not know it's malignant hyperthermia, but they're like, oh yeah, my mom almost died in surgery. This could be a reaction to that. It may prompt further investigation. But basically, it's fairly rare that it occurs. But you still want to screen for it in all your patients. But what happens is this altered ryanodine receptor, when being affected by the inhaled anesthetics or succinylcholine, basically it allows for all this calcium to flow out of the sarcoplasmic reticulum. Way too much calcium, okay? So you're in the skeletal muscle, releasing all this calcium. What does that do to the muscle? causes contractions, right? So you're contracting all that muscle. It can't get all that calcium back into the sarcoplasmic reticulum, so you can't relax that muscle, right? So it's constantly staying in this contracted state. So what do you think it does to like energy expenditure? It's pretty high, right? Because again, you're having all those contractions going on. What do you think it does to like things like heat production? We burn a lot of heat. So these patients get hyperthermic because of that, right? So all these muscles are cramping up. They can cause rhabdomyolysis to occur. They can lead to kidney dysfunction. These are things you want to be cautious with, right? So there are some cases where you can do different genetic testing, or you may actually be able to do a biopsy test to test for this. And typically those are going to be in patients who have a history that have a bad reaction or family history of bad reaction to anesthetics. So you're looking at this, you find the sarcoplasmic reticulum. This is the one that is the mutated ranitidine receptor that gets opened up and allows all this calcium to flow out. And again, you're going to be producing a lot of acid because you're going to be burning through so much ATP that you end up switching over to anaerobic metabolism, such that you get very acidotic as well. All kinds of bad things are happening here. You're going to burn through energy like crazy. You get lactic acidosis and this rigidity that occurs here as well. So what do we do for that? Also another thing as well, remember we talked about the relative concentrations of like sodium versus potassium outside and inside of cells? Where do we keep a lot of our potassium at? Inside of our cells. What happens if I start breaking down all these skeletal muscle cells? Hyperkalemia can develop, and they can develop arrhythmias because of that. So really, really severe when it occurs. It's pretty rapid in onset. It's one of those things you have to have a really rapid recognition of to get treatment started quickly. So what do we do for them? One, we want to cool them down. So typically in the ORs and in the ERs where you might use succinylcholine, in the ORs where you might be using a lot of these anesthetics, we have a malignant hyperthermia cart where basically it's like a little mini fridge filled up with IV fluids, and usually saline or lactated ringers. And then we have a cart that's just full of sodium bicarb. What's that going to do for us? It raises pH back up, right, because they're going to get very acidotic, and includes a drug called dantrolene. And dantrolene I mentioned before being used for NMS. This is the other thing that we can use it for. And so basically what it does, it helps to reduce that calcium being released from the sarcoplasmic reticulum. It helps to reduce that and will help to allow for the muscles to relax, right? So that we get the better, reduce that rigidity, reduce the rhabdo that might be developing there. And then we will also work to correct the electrolytes and once we get the acid base under control, we'll look at the electrolytes. I'll talk about treatment of hyperkalemia at another time. I won't get into that here, but there's several drugs we'll use for that. So key points, basically these are nice because one, they provide pretty quick onset of action, quick offset of action such that patients can wake up and recover sooner after surgery. They provide nice amnestic benefits there, and they're going to be used in conjunction with IV anesthetic. That's the next thing we'll get to, is all the IV anesthetics we will be using. Again, their onset and offsets all going to be related to the solubility, so how lipophilic they are to get across from the alveoli into the blood and then into the brain itself. Remember, monitor for things like malignant hyperthermia. You notice that the temperature of the patient be going up, their entitled CO2 would start to be going up, they become very rigid. Those are things you'd be looking for. And then the post-op nausea vomiting, quite common. So what do I get for that? Get some Zofran. It's a very common. I see Zofran. Some of my anesthesia docs like to use Reglan instead. There's no rhyme or reason to one or the other. They both work quite well, so it doesn't really matter one way or the other. Okay. So I'll probably cut it there. Let me see if there's any questions. Seems like a good stopping point. Guessing we're getting antsy for lunch. Let us see. Isn't ether used to get your mana back up? It is. It is. Nice. For the 3 people that get that. Would you need a different amount of inhaled anesthetic in Colorado versus Florida? Actually, I don't know. That's a good question. I'd have to talk to an anesthesiologist or CRNA or somebody. I do not know. Maybe you would need, see, because the partial pressure of everything is lower up there because you're a mile up. So I would assume you need more. Maybe, I don't know.
They have like higher oxygen concentration in their blood too, don't they?
Well, they have physiologic changes that occur that allow them to carry more oxygen, like their hemoglobin changes and some other stuff. But yeah, I don't know. It's a good question. There's a lot of stuff I don't know as it turns out. But I will see you guys next time.